will I? Okay, so yeah, to be honest, I want to teach a few topics and I don't know how it's going to come out, but I found this new way to teach and I just want to teach a lot of people. First of all, does this work? General pathology, systemic pathology, then we'll do examinations, and these three, if you're done, there you go. Yeah, everything's fine. I just checked the stream and we can get started. Okay, let's start it. This is the examination and we can start with thrombosis. These are all for thrombosis. And then we have several injuries. Forensic pathology. Quite a few good things are here. And I believe systemic is a lot better. Because we have a lot in systemic. No, cardiovascular also. Things like. Right, let's start with atherosclerosis and with the normal stuff. So here we have we can talk about the normal loop over microscope. Appearance of normal coronary artery, no atherosclerosis, widely patently available missing. Then we have the formation of thrombus. First of all, for the formation of thrombus, you require platelets. So platelets will be there, and the platelets usually are required for the formation of thrombus. So the so there is shearing stress or turbulence in the heart vessel. There is additional molecule and chemokine receptors and certain which are activated, which all stimulate monocyte. This monocyte will further stimulate macrophage, which forms foam cells, and also CD4 and CD8, which are complement pathway. Okay, so another thing you should remember is the biochemistry, in which homocysteine is involved in making the endothelial injury or dysfunction. All of this actually stimulates the platelet. So before endothelial injury occurs, you actually require LDL. LDL is one of the biggest culprit for atherosclerotic lesions in the vessels. These LDL will get oxidized, and along with free radicals, due to conditions like hypertension, diabetes mellitus, smoking, all of which also stimulate the angiotensin receptors. So all of these three are involved in causing endothelial injury and dysfunction, which finally leads to formation of atherosclerotic plaques and fibrosis. And atherosclerosis is potentially a reversible process, but it can be done by usually eating fewer total calories and exercising more. So next we have a gross image of mild coronary atherosclerosis with a few scattered yellowish lipid plaques, as seen. Yeah. The degree of atherosclerosis is not significant to cause disease, but it could be a harbinger of future worse atherosclerosis. This is a proper image of how it looks in the microscope. So the degree is always much greater in the coronary artery, and the lumen is narrowed by almost half. Okay. Area of calcification is shown in the plot over here. Okay. Usually you require the stains which are way better at discovering the atherosclerotic calcification and all. I think we'll come up to it. So these are the cross section of atrioventricular, anterior interventricular left, which is anterior descending. Okay. This is the left anterior descending artery, coronary artery, which demonstrated more pronounced atherosclerosis with narrowing at the left. This is the proximal portion of this artery. Okay, so left is more proximal, and as we go on, it becomes distal. Yeah, and you can see over here also there is a lot of blood. Yeah, here also you can see plaques, but over here there is a little bit less plaque. So atherosclerosis is generally worse at the beginning of an artery, where turbulence of the vascular flow with ongoing endothelial injury is very much greater. Yeah. Okay. We go on to talk about atheromatous plaque in coronary artery. It shows endothelial denuration with disruption of the thrombus. This is the thrombus here. Actually, I think there are few more things to show. Yeah, I show the PDL over here, calcification over here. This is how the calcification generally appears. Yeah, and okay. We talk about the formation of thrombus over here. This is formed by the arterial media is at the left. That is the media of the vessel, and there are cholesterol which is present as clefts over here. And finally, you can see the foam cell, microphilic foam cells are right over here. All of these are pathology. These are the cholesterol clefts, and this is the intima, and this is the thorax of the thorax. Okay. We talk about the occlusive coronary atherosclerosis. The coronary at the left is narrowed by around 60 to 70%, and the right is enormous with evidence of various thrombus formation. So there may be thrombus formation over here. So this right here, they show you the recent thrombus. This is how it appears. This is the gross appearance of severe atherosclerosis involving nearly 100% of the artery. You can see that it's here. Yeah. Okay. And this is also another atherosclerotic plaque. This is recently into the plaque. This is one of the complications of it. Such hemorrhages could accurately narrow the lumen and produce acute coronary syndrome. There is ischemia and infarction. This is the anterior surface of the heart, which is having the dead thrombus. Over here you can see the coronary thrombus. The coronary artery is open longitudinally, and thrombus is present, which is here. The red thrombus is seen within the lumen of the coronary artery. Then we have the gross appearance of coronary thrombus. Then the thrombus over here occludes the lumen and produces ischemia and infarction of the myocardium. The atherosclerosis is an ongoing process. It takes years for clinical problem to appear. Then we have thrombosis also. Which we have seen previously also. This is a thrombus which is occurring in the small vessel. Then we have a specific sign, the vessel which is appearing tan yellow, and it is surrounded by a hyperemic border. This is a cross section of a heart, and you can see there is large myocardial infarction involving the heart, and that has a necrotic center. Ejection fraction of the left ventricle will be reduced to 3. Then we move on to cut section. you can see all the septum, and this is the left ventricle. All of them will have the myocardial scarring. Okay, myocardial scarring is seen from the endocardial surface here. You can see scarring somewhere here. In the septum also there is a little bit of scarring, and there also there is a little bit of scarring. Then we have previous extensive transmural myocardial infarction involving the free wall of the left ventricle. Although the thickness of the myocardial wall is normally superior, but it's very inferior, it is very thin. Thin area is area of ventricular aneurysm that has developed as a consequence of healing infarct. So this is all healed fibrous tissue. Such an aneurysm is it's non-contractile tissue, and it reduces the stroke volume and strains the remaining myocardium. Stasis in the aneurysm predisposed to neural thrombosis. So if there is a stasis of blood, it can lead to neural thrombosis. Thrombosis formation can happen, and they are actually very bad. They make it difficult for other people, other myocardial fibers. Okay. Now, we have peripheral lipid streaks in the aorta, and this is the earliest lesion of atherosclerosis. Almost everyone has them, and it's not exactly disease. Okay, it's precursor disease to more atherosclerosis for more atheroma formation to control. And this is just a cut section of lipid sheets. The white arrow denotes the most prominent fatty streak incidence, but there are other fatty streaks over there. Here and here you can see fatty streaks. Earliest lesion in atherosclerosis due to increased cholesterol, decreased HCl, which contributes to this process. Then, there are three aortas which are shown here: mild, moderate, and severe from bottom to up. This is very mild, this is moderate, and this is very severe atherosclerosis. Okay. So microscopically, the aortic aneurysm is thicker than the remaining medium. So this is the media, and that is the recent hemorrhage. This is all aortic aneurysm and erythematous plaque. There is amorphous pink material with slit-like cholesterol pressure. All of these are cholesterol clefts of the lipid material, and thrombus may form on top of such a plaque. Then if we go on to higher magnification, we can find foam cells, and you can also find the cholesterol clefts which are seen in atheromatous plaque. Percent clefts composed of lipid with few scattered foam cells. Okay, few lymphocytes also may be seen. Atherosclerosis may weaken the wall of the aorta. It may form aneurysm. Okay, atherosclerotic aneurysm typically occurs in abdomen portion below the renal arteries as shown here, but aneurysm can form proximal also. Aortic aneurysm get bigger than 5 to 7 centimeter in diameter and are more prone for rupture. They are very much prone for rupture. Atherosclerosis may also involve the peripheral arteries. Peripheral arteries as shown here in the CT. You can see that there is occlusion of a popliteal artery here, and there is also a collateral branch. It's going through a collateral branch so that it can supply the whatever is below. You can compare the left and the right, and that's the easiest way to do. AVI is to document peripheral vascular disease, and if manual pump, if AVI is less than 8.5, it is consistent with peripheral artery disease. So it's a ratio of ankle occlusion and brachial artery occlusion. So like the pressure in the ankle compared to the brachial artery. You take the BP of the blood pressure, systolic and diastolic, but you check the systolic itself, and you check it with the Doppler ultrasound device. Another important, you actually use a USC device for measuring this. This is an important factor. And with these, what is that? You can compare. You find the ratio of systolic, this brachius by ankle. This is your ankle brachial index. The name itself will say. Yeah. Sorry, I went behind. I went. It is anchor by breaking. Yeah, that is the AVI. Moving on. AVI less than 0.85 is consistent with peripheral artery disease. Okay, another measure of peripheral resistance is to by doing pulse volume recording. Yeah. Volume changes that occur with arterial flow to the lung, and PVR is performed by placing multiple cuffs, multiple places and all, and checking the vessel, how it pressure. Then we go on to teach about different kinds of atherosclerosis. There is hyperplastic atherosclerosis, which is most often in kidneys and in patients, and hypertensive emergency, which is malignant hypertension, and when systolic pressure is 180 or diastolic pressure is more. Okay, so the arterial wall is markedly thickened and uneven is narrow. That is normally normal atherosclerosis. Okay. Then there are sometimes these small arteries and arterioles can be damaged. They may undergo fibrin necrosis. Okay, this is very specific to vessels. They generally undergo fibrin necrosis. Yeah, fibrinoid necrosis. The pink material is important. This is actually a glomeruli. Okay, it is showing hyaline atherosclerosis, which can be seen in this glomerulus, which is stained with periodic acid shift. It shows nodularities, for example here, and you can also see a thickened arteriole. It is generally seen in patients with diabetes mellitus and hypertension. Next, we have the dystrophic calcification, which is von Kemberg's calcification. You can see that there is a purplish blue calcification in the media. Lumen is unaffected in this process. There are usually no renal, there's no real clinical consequence of it. It can be seen normally in older patients also, but if there is calcified muscular arteries on radiograph or pelvic region in an older person, this is the cause. It is a insignificant atherosclerosis. It may be a dysmorphic accumulation. This is how the pulmonary artery embolus occurs from DVT or any source from the legs. And this is actually, I think this is the pulmonary trunk and the arteries to the right and to the left. Okay, and it's showing the saddle thrombus maybe. Yeah, saddle thrombus. It is a thromboembolism. In such a thrombus, we have a high mortality rate. Here's another thrombus in the pulmonary section of the lung, and it may be small, medium, large. Small ones may be inapparent, medial may not kill the patient, but large ones are life-threatening. Recurrent embolism can lead to reduced pulmonary vascular flow, leading to pulmonary hypertension. PAH, pulmonary artery hypertension is C. Then we have thromboembolism, including the main pulmonary branch also. Breathlessness and death within minutes can be seen. Then we have pulmonary in the major trunk. This is the X-ray. Thrombus generally appears pink-like, and wherever in the space, this is a vessel wall, and there is a emboli. Okay, layering of the RBCs and the lighter pink fibrin meshing leukocytes and platelet occurred in the vein in which the thrombus is originally formed. Okay. Just a second. So thrombus is not a mobile thing. Thrombus is a stationary clot. Emboli is a moving clot, right? This is a thromboemboli. It was initially thrombus which became emboli. Okay, that's format is being referred. All of it. This is not a pure thrombus. This is not the site. It was site was somewhere else. Then it came here. Then we have pulmonary embolus, which is adherent to the pulmonary artery wall. This, if the patient survives also, thromboembolus will organize and for the most part should be removed. And it will be removed. Lines of Zar, which is alternative pale pink and band, like pale pink and like darker bands with fibrin and red bands of RBC. It is forming the true thrombus. Thrombus will be having these bands right here. And you can see here there is an infarction. Here, occlusion of the main pulmonary artery cannot kill the patient suddenly, but smaller pulmonary arteries have no immediate effect also. Okay, but medium-sized branches can lead to pulmonary infection in a patient with compromised cardiac or respiratory state. So pulmonary infarct is hemorrhagic because it's having dual. So initially you will be having from the brachial arteries also. Brachial arteries is one source of blood, and then you have the pulmonary artery. So even if this pulmonary artery gets occluded, brachial artery will be supplying the blood supply. So that's why it forms a hemorrhagic. This in fact is hemorrhagic because of it. Non-occluded brachial artery supplying the blood to the interstitium. But they of course do not prevent the infection, but it will supply the blood. Okay, next. We have hemorrhagic infarct, which is seen in places with some collateral blood flow can occur. For example, in the bowel. Usually, if there is an infarct, there is extensive anastomosing blood supply. First of all, we compare like a few celiac few places like this celiac trunk, superior mesenteric, inferior mesenteric is required for the infarction occur. So, if in these places, if there is an emboli which is formed, which is occluding these places, infection will occur. But with severe atherosclerosis and vasculitis, cardiac failure also it can be seen. Yeah. Okay, and this is just talking about infection with sarcoma. These three are few important places where it can occur. Liquefactive necrosis, which is occurred due to a thrombus which became an emboli. So thromboembolism, which is infecting the cerebral arteries. Okay, circle of Lewis. Another thing is there is a beginning cystic resolution. There is cystic resolution of the infect. It become a cyst type thing. This is again showing the heart with the necrosis here. loss of blood supply, coagulating necrosis. This is another special. This is a spleen which is showing a pale lymph, which is a gross wedge-shaped appearance. Okay. There are two splenic infarcts. I think this is a pale infarct and this is another infarct. As you can see, the remaining of the spleen is dark red. Electron microgram of a platelet. It looks like a chocolate chip cookie. But it's really very small. So when there is mediators such as ATP, they get activated. Platelet will release their granules to promote coagulation. They change the shape and become sticky, and they aggregate to form blood vascular holes, and they form blood vascular holes. Okay. All these are shown platelets, and these are all fibrils. These are some very important hypercoagulable states. This is a very common question which a lot of stroke cases in the young is being seen nowadays, and a few reasons of why those occurs are because they are having a hypercoagulable state. They are in a hypercoagulable state and they are more prone for coagulation disorders like infarctions due to thrombosis. So let's go in brief. So Atlas syndrome is circulating antibody. Okay, so these are circulating antibodies against which have affinity for phospholipid sources. They cause thrombosis in women and it also causes stillbirth. It is often acquired in nature from underlying disease, or it can be an idiopathic condition. So mostly SLE, anticoagulation and anticardial lipid antibody is most often implicated. Okay. Then we have factor 5 Leiden mutation. It is the most common inherited form of hypercoagulopathy. It leads to activated protein C, and resistance. Activated protein C resistance is present in almost 5% of Caucasians, but is rare in African and Asian ancestry. Heterozygous have a mild risk for thrombosis, but homozygous have marked risk. And it is autosomal. No, 1 second. Okay. There is impairment activation of factor 5 by protein C. Recurrent venous thrombosis can also occur. So there is recurrent venous thrombosis, and even in young patients and in women with stillbirth also can be due to factor 4 Leiden mutation. We talk about elongation factor. So elongation factor 8 is another cause. It is common as Leiden mutation also. Genetic environmental factors will be causing it. It basically increases. It says that oral contraceptive use increases the factor 8 levels. It results in DVT formation. More risk for DVT formation. Then we have malignant neoplasm, which are neoplastic cells which elaborate a factor such as the thromboplastin-like substance. It can increase the risk for thrombosis. Okay. And form of pyeloneoplastic syndrome, the name is Trousseau syndrome. Okay. It can be venous, which is more likely, or arterial thrombosis. Malignant neoplasm, Trousseau syndrome, thromboplastin-like substance. Very important. Then you have protein C, protein S, antithrombin 3 deficiency. It is autosomal dominant, which leads to recurrent venous thrombosis. Okay. Even starting in new patients, thrombosis is often spontaneous thrombosis without any other precipitating events detected by a laboratory testing for the coagulation factors. So it can be protein C, protein S, antithrombin 3 deficiency. Yeah. The sticky platelet syndrome is an autosomal dominant disorder. It leads to arterial and venous thrombosis, stillbirth also, maybe C. Stress is a precipitating event. Homocystinuria is in presence with elevated plasma homocysteine levels who have increased problems with atherosclerosis. They also have thrombosis also, very high risk. Cysteine is also shown to be a risk factor in formation of platelets. No? So that's why it is also a risk factor. It is also a hypercoagulable state. We have prothrombin mutation in the G2021A mutation, which increases the level and activity of prothrombin. It mildly increases the risk of atherovenous thrombosis, and mutation also is commonly seen more often in the southern European ancestry. Plasminogen abnormalities can also be there. It resembles protein C or protein S deficiency, but this can also have activator inhibitor also can be increased. Like it can be the deficiency of plasminogen, it can be deficiency or inhibitor can be increased. Okay. Then you have congenital dysphipinoma, which is a rare autosomal dominant disorder which can cause either thrombosis or hemorrhage. Let's see. Let's go on. Then we have an image showing the epicardium of the heart. This is the heart and it's showing petechiae, pinpoint hemorrhages all over here. You can see all over here. You can see. It is due to bleeding from small vessels, classically found in coagulopathy due to low platelet count, and it can be also be appear after sudden hypoxia. This one. How much more is there? Yeah. Around 4 more are there. I'll do this and I'll come back again. One topic, let's just keep on doing. In 1 hour, maybe 20 minutes, I'll do a topic. I'll take a little bit of break. I'll do another topic, break, and we'll finish off pathology. Okay. There's not much in this website. So yeah, let's see. We have blotchy areas of hemorrhage. This is called as ecchymosis. These are bigger than petechiae. Yeah, they're larger than petechiae, and they are hemorrhages, which is also called as purpura. So in between this ecchymosis, petechiae, these are generally less than 0.5 mm. Then you have purpura, which are like 0.5 to 2 or maybe 3 mm. These are smaller than ecchymosis. So more than 3 mm. Actually, I think it's centimeter. These are not very important, but the order is the only thing which I remember as something which is very much important. Yeah. Okay. With coagulation disorders, even in the setting of normal tissues, associated to significant trauma also due to ruptured blood vessels and soft tissue bleeding also they may occur. Yeah. It is called as contusion if in case of trauma. This is image showing a hematoma which has been formed beneath the fingernail. It has a bluish appearance due to deoxygenated blood within it. Okay. So you can see that this is a vessel here. Yeah, and that is the thrombus. Yeah, that's all this is. They also talk about disseminated intravascular coagulation, which is a consequence of widespread activation of coagulation system, and there is fibrin loss. Yeah, like severe infection, trauma, neoplasia, and most worst cause of DVC, obstetric complications. So many people lose their life because of this. Small fibrin thrombi can form in small arteries of brain, lungs, kidneys, and other organs, which produce ischemic tissue damage. Treatment is very difficult. You have to provide heparin, and even then, safety cannot be assured in case of acute DIC. In case of chronic DIC, it's a little bit better prognosis, but nonetheless, it is a very dangerous disease and very dangerous condition. We have a small fibrin thrombi. It is widespread activation of the coagulation system. There is disseminated intravascular coagulation. It can be seen in capillary loops in glomerulus. Yeah. Small fibrin formation which is occurring here. DIC, it is a bit fibrin stain also. So laboratory findings include decreased platelets, decreased fibrinogen, increased prothrombin time, elevated partial PTT, APTT, PT, APTT. There is elevated D-dimer also. This is a very important sign. Consumption of coagulation factors is seen with generation of fibrin split products. Okay. Along with platelet consumption, so fibrin split products and platelet consumption leads to these findings. That's all we have with this process. Next we'll do injury and forensic pathology. Forensic pathology is more beautiful. Then neoplasia, I think neoplasia might be this section. If I have good pathology slides, it's good. So I will stop this for now.